Hello, my name is Robert Whitaker, and I want to thank Joanna for giving me this opportunity to say a few words about Anatomy of an Epidemic now that it's been translated into Polish. Now, this book, which was initially published in 2010, and then it's been updated several times as translations have been made of the book, really focuses on this bottom line question. How do psychiatric drugs affect the long-term course of major psychiatric disorders? In other words, how do antidepressants affect the long-term course of depression? How do stimulants affect the long-term course of ADHD? And actually, most important or most crucial, I'd say, is how do antipsychotics impact the long-term course of psychotic disorders, including schizophrenia? And the reason I think that is so important is because the most firm belief in our societies is that antipsychotics enabled the emptying of asylums, made it possible for people with schizophrenia to live in the community. And for example, Edward Shorter, who's a well-known historian from the University of Toronto, said in his book, A History of Psychiatry, that antipsychotics represented a great advance in care, as significant an advance as the introduction of antibiotics into infectious medicine. Now, if that's true, that's a story of a great advance. And this belief is really part of the conventional history of psychiatry, that it enabled patients, like schizophrenic patients, to live outside the asylum, and also that there's really good evidence that they're essential for the short-term and for the long-term use. So Joanna asked me to give a little presentation around that particular part of the book in terms of what is the evidence regarding antipsychotics on the long-term course of psychotic disorders and schizophrenia. Now, the first thing you need to do when you take this on is to look at, well, what is the evidence for their long-term use? And very quickly you find that it consists of relapse studies. And these are studies in which researchers, and these go back many years to the 60s and all, where you took patients who had responded well to the drug. Now, you need the select group of patients who've responded well because they need to be not psychotic at the start of the study, and then you're going to look at who becomes psychotic during the course of the study. And what you find, and the way these studies were designed was this. You would take this group that was good responders, and one half would be randomized to placebo. In other words, they've been withdrawn from the drug, and the other half would be maintained on the antipsychotic they've been on. And with great regularity, those who were maintained on the drugs had lower relapse rates than those who were withdrawn from the drugs. Now, what the researchers said at this time is, see, in the absence of the drug, once it's withdrawn, the disease returns. And that's basically the evidence that has been given for many decades as to why people have to stay on the drugs, why people so diagnosed, is that the drugs reduce the risk of relapse. But of course, you have to examine this research design and say, what does it really show you? First, it's being done only in good responders. So it's not showing you, in other words, people, that select group that have responded well to the drug. So it's not telling you about how it affects the long-term course of everyone so diagnosed. That's number one. Number two, it's telling you that after when the drugs are withdrawn, there is a period of increased risk of relapse for those that are withdrawn. But that's not necessarily the return of the disease. It's very likely due to withdrawal effects. So there's a confounding factor. The next, those studies, when you look at relapse rates following a withdrawal of the antipsychotic medication, it doesn't tell you what's happening over even longer periods of times. Like, how's it affecting people at the end of 1 year, 2 years, 5 years, 10 years, 15 years? All those studies are really telling you that in patients who've responded well to the drugs, if they try to come off, especially abruptly, because most of the drug was withdrawn quite quickly, you're going to have a higher risk of relapse after that drug is withdrawn for some period of time. But it doesn't tell you anything about long-term functioning, especially long-term functioning in the aggregate. And not just on symptoms, but how well are they working, how well they're doing, that sort of, they socializing, et cetera. It's not just symptom reduction. So, and this lack of a good evidence base is actually well recognized. There was a man named Emmanuel Stipp, a psychiatrist from Montreal in 2005, and he said, when you really look at the evidence base, we don't have good evidence that these improve the long-term course of schizophrenia and psychotic disorders, that is, antipsychotics. And once you understand that there's many confounders to that. It's conducted in good responders. The placebo group isn't really a placebo group; it's a drug withdrawing group. And three, the studies aren't telling you anything about the long-term functioning. That opens up an inquiry into looking at, and which is what I did in Anatomy of an Epidemic, is how are these drugs affecting the long-term course of psychosis and schizophrenia? So now how are you going to do that? Because you can't just turn to randomized studies. There's not randomized studies that have one group that's randomized to drug and one group randomized to no drug, and you're going to follow them for 20 years. Well, it's like putting together a puzzle pieces that will go back in history, and you're going to have about a long period to see if those puzzle pieces fit together. Now, the first thing you have to do is try to understand is, what was the course of schizophrenia in the time of those diagnosed with schizophrenia and hospitalized in the decade before the arrival of antipsychotics in asylum medicine in 1955? And right away you come upon a surprise, because the conventional wisdom is that prior to the introduction of antipsychotics, people lived couldn't live in the community. They were basically chronic patients, and they were mostly remaining in the hospital. Well, if you look at outcome studies in the United States and other countries as well, say from Norway, that follow a cohort of first episode patients, what you find, for example, in the US studies, is that anywhere from 65 to 80% would be discharged within a year of their admission. And then if you follow them up anywhere from 3 to 6 years, roughly 2/3 would be living in the community. Now, maybe some of them had a second episode and come back, but at the end of 3 to 6 years, roughly 2/3 or 70% in the US studies were living in the community. And what's interesting about this is this was before we had any social service disability system for people with psychiatric disorders. So people were working. I think employment rates were above 50%. They were getting married, actually, some people, et cetera. And so what you see here is that a majority of people actually could have recovered to the point, and this is before antipsychotics were introduced, to be able to live in the community. And once they were there, they were functioning to some degree successfully. Okay, and only about 1/3 were really becoming chronically ill, where they just were 33% couldn't really live in the community, and then were going back and living in the asylums. That's in the decade before 1955. So right away in this search through history, you see a surprise that, in fact, in the US, Norway, other countries, that many people so diagnosed from a first cohort of psychosis/schizophrenia would recover, and once recovered and return to the community, a high percentage, in fact, would be able to function okay, and maybe now and then go back to the hospital, but often just remaining out of the hospital. They would have a time of schizophrenia. Now, going forward, so these drugs are introduced in the United States in the mid-1950s. And if you look at clinical perceptions at this time, you see doctors, psychiatrists, asylum psychiatrists, and others saying this: boy, it looks like maybe my patients are getting better faster, but it also seems that they're relapsing more frequently than before. And they even came up with a term to describe this new course. They called it the revolving door syndrome. They leave and come back, leave and come back, and leave and come back. So that's a clinician's perception. That's a second little bit of evidence here. So now in 1970s, early 1970s, researchers at the Boston Psychopathic Hospital got an NIMH grant to study outcomes, 5-year outcomes from a cohort of patients they had treated in 1947 with mostly psychotherapy and psychosocial care, but this was before they had the drugs, with outcomes with a similar cohort of patients treated in 1967 with psychotherapy, with psychosocial care, but also with antipsychotics. And what they found at the end of 5 years was that the relapse rate was slightly higher for the group, the 1967 group, but even more important, they found that the 1976 group were much more socially dependent. They were on welfare and needing other forms of sort of social support than the 1947 cohort. So what they concluded, and the man's name is Bachhoven, who was the first author on this, he said, maybe these drugs are making people less able to function well in society over the long term. And maybe we need to revisit our long-term use of these drugs, at least for a significant percentage of patients. Now, this in the late 60s, this starts to lead to some questioning of the use of these drugs, particularly over the long term. And of course, there was some movement disorders showing up. Tardive dyskinesia was starting to show up. So in the 1970s, the National Institute of Mental Health, which is in the United States, the leading research, the government funding of research for mental issues, psychiatric issues, funded 3 studies that were designed to assess whether immediate use of the medications and regular use of antipsychotic medications, how did it compare to where you initially didn't put people on medication and tried to keep them off, and what were the outcomes for at the end of 1 year, 2 years, and 3 years? Now, these were randomized studies, and one was done by a man named Maurice Rappaport at a hospital, in a setting at a hospital in California. People came into the study. They were either randomized to no drug or randomized to drug. Then they would be discharged after they got better, and then they would be followed up for 3 years. Now, in the follow-up period, people were able to, so let's say you were randomized to no drug, and then you're discharged. Now it becomes a naturalistic study. Some of those people may go on medications, and conversely, some of those randomized to drug may stop taking the medication. So what did Rappaport find? He found that 2/3 of the patients randomized to no drug, never needed to go on the drugs in the 3 years. And it was this group, 2/3, that had by far the best best outcomes at the end of 3 years. Now, remarkably, the group that had the worst outcomes was the group that was randomized to drugs and stayed on the drugs for all 3 years. So what does Rappaport say? He says, boy, we need to reconsider this, because it seems like, at least for a significant percentage of patients, they would do better if they weren't being immediately treated with the medications. They were treated in some alternative manner. The second study was run by Loren Mosher. He ran a project called the Soteria Project. It's a pretty famous project. And he was head of schizophrenia studies at the NIMH at the time. Same sort of thing. Here was the design. People either they would be brought into the hospital. Most were first episode, or they tried to get first episode and young. And they would either be randomized to stay in the hospital and treated with drugs, or they would be randomized to treatment in a residential center, sort of staffed by ordinary people, where they wouldn't initially be put on medications. Now, if they didn't get better after a certain period of time, they would be put on antipsychotic medications. So what did they, and this was a 2-year study, what did they find? They found that the residential care that involved minimizing use of medications, 40% of their patients never went on medication during in the 2 years. About 40% used them temporarily and 20% chronically. That form of care where they use the drug selectively produced better long-term outcomes. And once again, Loren Mosher said, boy, we need to rethink use of these drugs. Now, the third one was run by William Carpenter. He's a very famous psychiatrist studying schizophrenia in the United States. He compared psychotherapy with drug to psychotherapy without drug. And once again, at the end of 1 year, it was psychotherapy without drug that had the better outcomes at the end of 1 year. And at this point, so you have 3 studies, and they're all at least raising this possibility. There's a significant group of people who would do better and could recover if they were not medicated. And that because of that, the overall outcomes were worse with this paradigm of care that emphasized immediate use of the drugs and regular use of the drugs. Now, at this point, this is the late 1970s, there's 2 papers that come up. One is a paper by Jonathan Cole, who was head of the Psychopharmacology Service Center in the United States. He wrote a paper called, Is the Cure Worse Than the Disease? Because of all the side effects. And he urged that everybody be given a chance to go off the medications. And then William Carpenter, taking stock of these 3 studies, wrote this. There is no question that once patients are placed on medication, they are less vulnerable to relapse if maintained on neuroleptics. That's the relapse studies. But what if these patients had never been treated with drugs to begin with? we raised the possibility that antipsychotic medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. Thus, as with tardive dyskinesia, we may have a situation where neuroleptics, antipsychotics, increase the risk for subsequent illness, but must be maintained to prevent this risk from becoming manifest. So this is an uh-oh moment. They're saying that the very drugs that are used to diminish psychotic symptoms over the short term may be causing a biological change in the brain, inducing a change in the brain that makes people more biologically vulnerable to psychosis than they would be in the normal course of the illness. So at that point, two Canadian researchers, Barry Jones and Guy Chenard, came forward with a biological explanation for why this seemed to be so. And here was their explanation. Antipsychotics work by blocking dopamine receptors in the brain. The brain, in response to that blockade, tries to up its dopaminergic in machinery. In other words, the drugs act as a brake. The brain tries to put down the accelerator. And one of the ways it does so, it increases the density of its receptors for dopamine. And they said, now the brain there's a dopamine supersensitivity in the brain, and this it seems to increase the risk that people would become psychotic. And they did a study, and they said when this happens, when you get this sort of increase in dopamine receptors, you often see what's called the tardive psychosis set in. And when that happens, they said this: neuroleptics can produce a dopamine sensitivity that leads to both dyskinetic, that's the movement disorders, and psychotic symptoms. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. And in their studies, they also found that symptoms, once this supersensitivity develops, can lead to more severe symptoms than they had ever experienced before. So that's the situation. That's the history through about 1980. That's when the Chenard and Jones write this. And what you have there in this first 25 years of evidence base, or you might even say 35 if we go back to the decade before the introduction of the drugs, we have information of high discharge rates and basically high able to live in the community rates prior to antipsychotics, arrival of antipsychotics. Then we have a study that shows with antipsychotics people are becoming more socially dependent. Then we have 3 NIMH studies that say, wow, on the whole, you see with this paradigm of care that emphasizes medication use right away and continually is worsening long-term outcomes. And then you come with people saying, oh, we think we know what's happening. The drugs act as a brake. The body, trying to maintain a homeostatic equilibrium, maintain its normal functioning of its dopaminergic pathway, increases its dopaminergic activity in the form of increasing its density of dopamine receptors. And once this happened, they said, now the patient is more biologically vulnerable to psychosis and more biologically vulnerable to more severe symptoms. Now that comes together in 1980. Now it's 2024. And now what we want to do in the next 10 or so minutes is look at, do we have evidence that says, oh, that worry we should still be worrying about this worry? That maybe the drugs are in fact worsening long-term outcomes? Or for whatever reason, do we have now new evidence showing, no, this paradigm of care we have that uses drugs right away, antipsychotics right away, and maintains on drugs on right away, that it does provide a long-term benefit? And I'll review this real quickly, but what you want to do now is look at every type of study you can find to see how it bears on this question of what is the long-term impact of antipsychotics. Now, for example, there are cross-cultural studies that were done by the World Health Organization going back to the 1970s, late 1970s, in which they compared outcomes in 3 developing countries, India, Nigeria, and Colombia, with outcomes in the US and other developed countries. And each time they concluded that outcomes were much better in the developing countries, and particularly India and Nigeria. So much so they concluded, and listen to this, living in a developed country is a strong predictor that if you're diagnosed with schizophrenia, you won't have a good outcome. Now, after the first such study, the researchers hypothesized, well, maybe one reason for the better outcomes in the developing countries is that the patients are more medication compliant, which makes sense because if medications are supposed to be so helpful, they shouldn't change the course of the disorder to a more beneficial route or less severe route. And so medication compliance should be associated with better outcomes. So in the second such study, and I think that was the 2-year study, they measured antipsychotic use. And what they found is in the developing countries, and particularly India and Nigeria, where the outcomes were the best, they used the drugs acutely, but not chronically. And by the way, everybody was diagnosed by Western doctors, so the diagnosis was standardized. In the developing countries, only about 16% of patients were maintained on the drugs long term. Now they did use them acutely, but they didn't maintain them on long term. And in India and Nigeria, it was even much lower, like 10% were maintained on drugs long term. But that's the standard of care in the United States. So in these cross-cultural investigations, studies by the World Health Organization, outcomes were much better in those countries that use the drugs acutely but not chronically. And by the way, the investigators went back at the end of 15 years and they found that outcomes were still much, much better in the developing countries. They were much more likely to be asymptomatic, socially functioning okay, working, that sort of thing. Okay, that's cross-cultural studies. Now, next in the 1990s, we get MRI, magnetic resonance imaging technology, which allows researchers to start taking pictures, measure assessments of brain volumes, including in schizophrenia patients. And then in the 1990s, Nancy Andreasen, who was the editor-in-chief of the American Journal of Psychiatry, launched a big MRI study of first episode schizophrenia patients. And she had this hypothesis. Schizophrenia is a neurodegenerative disease, and over time, we're going to see a decrease in volumes. And unfortunately, the drugs may not arrest, they may not stop that neurodegenerative process, which leads to this decrease in brain volumes. So she does this study, big, large study, first episode, and I forget what year it was she first reported, but around 2000, she reports, yep, that's what we're seeing. Whereas we're seeing a diminishment in brain volumes, frontal lobe volumes, white matter volumes, and this seems to be a disease process. That's what she says. The next thing she says, you get this decrease in volumes, you get worse psychotic symptoms, worse negative symptoms, that's lethargy, etc., and more functional impairment and cognitive impairment. So you have here a biological change in the brain, in other words, a decrease in volumes. And as that decrease happens, you see a worsening of outcomes, people getting more severe symptoms, less functioning, etc. However, there had been a study done in monkeys who obviously didn't have schizophrenia. And in that study, it was reported that antipsychotics given to the monkeys that, in the one arm, it caused a reduction of volumes in the monkey brains. And of course, compared to the monkeys that weren't given the drugs. So now we have a sense that maybe, and it was dose related. So now we have a study saying maybe it's the drugs that are causing this reduction of volumes in the brain. And so Nancy Andreasen and colleagues went back to their studies, to their data and their studies and information they had. And they said, the severity of it, this reduction in volume of brain volumes is not associated with severity of illness or either, I think it was either substance abuse, but it was associated with use of neuroleptics, and it was dose related. So what they're saying at this point is it seems that antipsychotics shrink the brain, and Nancy Andreasen told this even to the New York Times. And then if you put all our research together, you see antipsychotics shrink the brain. And by the way, this included the second generation of antipsychotics like Zyprexa and risperidone. So what you see is an iatrogenic process. You see drugs that cause a measurable change in the brain, a shrinkage of brain volumes, and as that happens, you get worse psychotic symptoms, worse negative symptoms, and worse functional impairment and cognitive functioning. That's a picture of an iatrogenic process. Now, the next thing we have is a study done by Martin Harrow and Thomas Jobe, Martin Harrow's a psychologist, Thomas Job was a psychiatrist, and they did their study in Illinois at 2 Chicago area hospitals, one public and one private. That way they got a diverse patient group. And it was just a naturalistic study. Everybody and it was a big study. They enrolled 200 patients into their study. Some get diagnosed with schizophrenia, some with milder psychotic disorders. Everyone is treated with antipsychotics, and then they're discharged. And then Harrow and Job are just going to follow them up periodically at 2 years, 4.5 years, 7.5 years, 10 years, 15 years, 20 years. And at each time they're going to measure, are they using medications, antipsychotic medications? What are their symptoms? Are they functioning well? In other words, are they working? Do they have good social functioning? What's their cognitive functioning? What's their anxiety levels? A complete sort of assessment of how they're doing. Now, at the end of 2 years, they end up with still having 145 of the 200 patients in their study at the end of 15 years. And at the end of, and 64 are patients diagnosed with schizophrenia, and the other 81 are with milder psychotic disorders. Now, among the 64 with a diagnosis of schizophrenia, 25 by the end of year 2 have stopped taking their medication. Now, at the end of year 2, there's a little bit better outcome for those who've stopped in terms of functioning, et cetera, recovery. But it's not that much different. But now what happens between year 2 and 4.5 is that the group that has gotten off medications continues to get much better, much more stable, much more functioning, whereas the group on medication does not. In fact, if anything, it starts to worsen a little bit. And at the end of 4.5 years, you see that 40% of those off medication are in recovery. And recovery means you had to be asymptomatic and you had to be working or in school half-time and have a decent social life. So it wasn't just a symptomatic measurement, versus a 5% recovery rate for those who were medication compliant. And that difference, that 8-fold higher recovery rate remained throughout every follow-up and was still in place at the end of 15 years. Now, they've published a number of papers, and they looked at recovery rates, and that's the one, number one. They looked at outcomes for those with milder psychotic disorders. Those who got off had significantly better outcomes. Going back to the schizophrenia group, they traced cognitive function. Those who got off had better cognitive function. They had less anxious symptoms. They were much more likely to work. And they were also, he eventually groups his outcomes into 3 types: recovered, so-so, uniformly poor. And only a small group were uniformly poor of the group that got off medication, whereas nearly half those on medication were in that universally poor group. So it wasn't just that there was a higher recovery rate. It was like the whole spectrum of outcomes was what was much worse for the medicated patients. And remarkably, here's what he found. There's a couple of things here. One, he found that once people got stable off medication, okay, and by the way, at year 2, many of them were still psychotic, but they got stable off medication. They had extremely low relapse rates or return of psychotic symptoms. Whereas those who were medication compliant through the total time of the study, they often were having psychotic relapses, sort of consistent with the dopamine supersensitivity theories, such that like the majority would be having psychotic symptoms. So rather than see the drugs effective in reducing psychotic symptoms over time, you saw this dramatic divergence between those who got off and stable at some point versus those who remained on the drugs. Now, the other thing that's really important here is this. So, and he concludes this. I'll just say what he said at the 2008 meeting of the American Psychiatric Association, when he presented on this long-term study, which was funded by the NIMH. By the way, it was supposed to, their hypothesis was that those who stayed on the medication would have the better outcomes, but it was exactly the opposite. And this is the best, most comprehensive longitudinal study of schizophrenia outcomes that's been done in the modern era. And here's what they concluded in 2008. I conclude that patients with schizophrenia not on antipsychotic medication for a long period of time have significantly better global functioning than those on antipsychotics. So what you're seeing is these different types of studies, cross-cultural studies, MRI studies, the best longitudinal study. They're all confirming that earlier worry that showed up in the first 25 years that these drugs, over the long term, increase the risk of psychosis and impair functioning on the whole. It doesn't mean that nobody does well or that everybody can get on, but these are aggregate outcomes. Now, since then, in the last 10 years, you've seen studies of different times assessing long-term outcomes. They come from the Netherlands, Australia, UK, Denmark, Germany, Finland. In this short time, I don't have time to go through all the studies, but every single study has found that recovery rates are higher for those who can get off the medication. So over and over again, we're seeing the same bottom line finding. By the way, you can go on, much as this is in the updated book, updated version of Anatomy of an Epidemic that was translated into Polish. And then there's also been some updates you can find on madinamerica.com. If you go there, you'll see on the menu bar a thing that says drugs, and drop down, it'll say like antipsychotics. You can go there and there'll be an update of research of this sort with links to the studies. So the question is there an alternative? Now, we saw before 1955 that many people were getting well. And if you go back through history, there's a form of care in the 1800s and known as moral therapy that also produces good outcomes. It sort of doesn't treat it as necessarily a biological disorder. But the beauty of this story about antipsychotics is that there is a group in northern Finland that rethought their care going back to the late 1980s and early 1990s. And they developed something called open dialogue therapy. I'm sure you've heard of it. And it was led by a man named, the psychiatrist was named Birgitta Alekari, and the researcher was named Jaakko Sekala. And here's what the sort of what open dialogue was conceived of as by them. They said the psychosis doesn't occur in the brain of the individual, but rather in the in-between spaces of people. And the person who is psychotic is bearing the burden of making known this disruption of spaces in between people. And so what they need to do is repair those in-between spaces. So what they do is when someone has a psychotic episode, right away they bring a group of people, or at least two people, out to the home or out to where the person is living, and they start having a dialogue with not only the person, but people in that person's social world, if possible. And second of all, they don't put people on antipsychotics right away. At least this is how it was done in the 1990s and 2000s when Birgitta Alekari was there. And instead, they had this thing called a grip on life. As long as a person, while they were getting this sort of psychological therapy, was showing that a grip on life was improving. In other words, maybe they're showering, they're more willing to engage in these meetings and that sort of thing. They would refrain from using antipsychotics. However, if after some time they weren't getting better, they would use a low dose of chlorpromazine. The idea was they would stabilize them. And then after stabilizing, they would see who could then come off successfully. So it's a selective use model with intensive psychosocial care right from the beginning. And we could go into it more, but it's about building a narrative where the person can see themselves as being with other people before. They can look back to a time when they could be with the people before. And now in the future, they can imagine being with people again and imagine a good future for themselves. And here are their outcomes. At the end of 5 years, and this was reported by Jaakko Sekala after studying several cohorts of patients coming through their program in Tornio, Finland, which is in Western Lapland and Northern Finland. At the end of 5 years, 67% of their first episode patients have never been exposed to antipsychotics. And in terms of ongoing use at 5 years, it's only about 20%. So there was about another 13% that used them temporarily but didn't need to stay on the drugs. And now here are their outcomes. The group percentage that never relapsed after first stabilizing during 5 years, 67%. The percentage that were asymptomatic at the end of 5 years, 80%. The percent unemployed, 7%. On disability, 20%. In other words, you see a complete shift away from a chronic course to where most of the people had a time of psychosis, and most were able to rejoin society, get back to work, and that sort of thing. And by the way, getting back to work is an essential part of what they accept to do. So here's what Jaakko Seikkala says about this, using neuroleptics, antipsychotics in a selective fashion. I am on the importance of doing so. I am confident of this idea. There are patients who may be living in a quite peculiar way, and they may have psychotic ideas, but they still can hang on to an active life. But if they are medicated because of the sedative action of the drugs, they lose this grip on life, and that is so important. They become passive and no longer take care of themselves. So that's a very short version of the research literature, the evidence base regarding how antipsychotics affect the long-term course of psychosis and schizophrenia. And what you see, of course, in this evidence base is a moral challenge to practitioners to reinvent ways in terms of how you treat first episode psychotic patients, one that at the very least tries to minimize or use the drug selectively and minimize their long-term use, and and embrace these sort of intensive psychosocial ways of helping people. That, in my opinion, that's what this evidence base presents to therapists and people working in this field, a challenge to really rethink the use of these drugs. Now, that's the story for antipsychotics, and if there's any class of drugs we should expect to have a benefit based on the conventional narrative, it would be antipsychotics. But what you see, and you'll see this in Anatomy of an Epidemic, the evidence is quite powerful, quite strong, that antipsychotics increase the chronicity of depression, the likelihood that people will be depressed years later, and increase the likelihood of they'll convert to bipolar, and that they'll become functionally impaired. With stimulants, you also see, on the whole, that they worsen long-term outcomes for kids diagnosed with ADHD. And you can also see that medication treatment of bipolar disorder, used to be manic depressive illness, that bipolar disorder now runs a much more chronic course than manic depressive illness used to. So I think what you see, if you look at the evidence over a long period of time regarding the impact of psychiatric drugs on major psychiatric disorders, you're not seeing a long-term benefit, a lessening of the burden, an improvement in functioning, a lessening of the symptoms. What you're instead seeing, and this is tragically, an increasing chronification of these disorders. Well, I want to thank you for this opportunity. That was sort of a Cliff's Note version of this. I hope this can get translated into into Polish. And thank you for this opportunity. And thank you for this opportunity to have Anatomy of an Epidemic translated into Polish. Thank you.